Welcome to the University of California, San Francisco Sports Medicine Podcast, featuring Dr. Nira Fundia, Dr. Brian Feeley, and Dr. Drew Lansdown, discussing hot topics in sports medicine and society. We hope you enjoy our podcast and look forward to hearing from you.
Today on 6 to 8 Weeks, we're going to talk about pain in the front of the knee. This is kind of a grab bag of problems from runner's knee, kneecap instability, and patellofemoral arthritis and cartilage loss. When we talk about anterior knee pain, the anatomy is both simple and complex. The kneecap sits in a groove in the femur or thigh bone and acts as a lever for your quadricep to be a little bit more strong. There are also soft tissue restraints to the inside and outside of the knee that hold the kneecap in place. And these also have a lot of nerves that sense where your knee is in space, kind of your proprioception, and lets your knee know what the relative loads are that go across the knee joint. You also have your patellar tendon and quadriceps tendon, which can get overused in jumping sports and running. To make matters a little bit more complex, the muscles in the back of the knee, your hamstrings, and the ones up by your hip, your core muscles, such as your butt muscles, your groin, and low back muscles, also control your knee and are really important in maintaining balance and control. Pain in the front of the knee is incredibly common. A study in 2018 out of the UK Healthcare database showed that 22% of people will have pain in the front of their knee in any given year, but it's actually higher in younger, more active people. Yet fewer than 1% of people with patellofemoral pain need any type of surgical procedure for this. So you have a common problem, worse in people that are trying to be active, but we still are challenged in how we diagnose and manage these patients. We are going to talk today with Drew Lansdown, my partner and colleague who excels at managing these patients. All right, welcome back, Drew. I thought today we would talk a little bit about our most common problem overall when it comes to knee problems. I'd like to think it's ACL tears, especially this winter in California with the amount of skiing that we've had. We've had obviously a ton of knee injuries and a lot of ACL injuries from skiing. But I wanted to talk about anterior knee pain and particularly patellofemoral pain. So when we think about patellofemoral pain, what goes through your head when people say, I've got pain in the front of my knee, or I've got a problem with my kneecap or patella?
Yeah, so it's, I think, a really interesting area because there can be so many different issues that contribute to the pain and the problems. I think the first thing I think of is that usually we can get that pain better without surgery. I think that's like the main, probably most important takeaway for most people. But it is can be hard to figure out exactly what's causing the pain. And then, there's a multitude of different things that need to be done to get it better. But most of them are non-surgical, which is a good thing.
Yeah, I like to think about patellofemoral pain as kind of dividing into three general topics. One is this vague, probably ill-described and poorly described patellofemoral pain, where you have pain in the front of the knee, but there isn't necessarily a structural problem, and we'll get to that one as well. One where your kneecap dislocates or wants to dislocate, it slips out of its groove, and I think that one's pretty straightforward in terms of our treatment. If you've dislocated once, we can treat that usually non-operatively, but once it happens a few times, you need to think about treating that with some sort of surgery so you don't start beating up cartilage. And then the other one is when you start developing cartilage loss or early arthritis underneath the kneecap. So when you have a patient with anterior knee pain, let's start with that first one, because I think it's a vast majority, probably 90% of patients. Why do people without any structural problems have pain in the front of the knee?
Yeah, I think we think a lot of it is the relationship of the muscles around the knee. The kneecap depends so much on the soft tissue around it and the muscular control. So the kneecap itself, it's called a sesamoid bone, but it's a little bone within a couple tendons. So you have the quad muscle that turns into the quadriceps tendon, and then the patella sits in that, and then the patellar tendon connects it to the tibia. But so it's, sitting within that muscle basically. And then the femur below it's controlled by all of the muscles up by the hip. And so you have all these muscles that need to work appropriately together. Otherwise, the forces that are transmitted to that bone are, you can overload certain areas or have, different problems. And then there's also so many other soft tissue structures around the kneecap that make sure it stays in place, keep it tracking appropriately. And then those can be overloaded too. And we think that can also cause pain.
Yeah, I think the idea of overload is interesting because it's not necessarily that you're causing some sort of damage, but your body is just reporting it feels different. And
Right.
the problem with our knees in particular, it seems like, or realistically other parts of our body, but since we're talking about knees, is that we don't have a way for our knee to say, you're overloading the front of the knee, so it just says, ow. And I think that's one of the limitations is we have such this amazing language to be able to talk about whatever we want. We can talk about knees, we can talk about ACLs, we can talk about disparities in healthcare. All your knee can say is, it feels different. So I'm going to say, ow. And then our reaction to that is usually, well, I've got to stop what I'm doing because I'm really worried that I might be causing something to break down or further injury, when all the ow is saying is we need to rebalance our muscles. Now, you gave a really good talk at our annual academy meeting on exercise and patellofemoral pain, especially in this setting where there isn't anything structurally wrong. Can you talk about some of the findings that you reviewed and how exercise and what exercises can really help people with anterior knee pain?
Yeah, and I think the most important thing is that there is evidence that supports that exercise helps with resolving the pain. So it is an effective treatment. It's also really safe, and so that's usually what we start with treatment because it works, and it's not risky. And then there was one study that I thought was really, really interesting that they looked at how the patella is loaded on imaging, and before and after like a strength training regimen. And they actually saw that the cartilage contact, so the way that force is distributed across that joint, it changed before and after exercise. So it seemed like strengthening led to better load distribution through the knee, which it would seem like that can kind of explain why the pain also gets better. So I thought that one was really a really interesting finding. And then, another thing that kind of stands out in looking at a number of studies is that blood flow restriction therapy. So it's something that's gained a lot of traction lately in both medicine and in just like strengthening and performance, but where you put a blood pressure cuff on the leg or extremity while doing exercises. And there's like machines that do this appropriately. And then it lets the joint work without overloading it, a kind of lower level intensity that can still really exhaust the muscle. And there's a couple studies that show that it's more effective than regular exercise alone for this anterior knee pain, which I think also makes sense where, if you say, well, it hurts when I try to do things because I'm overloading that area. And so I can't do anything, but the answer is to, build up that strength and control. It seems like this might be a nice way to get started and to make progress and kind of like break that cycle and get the knee feeling better.
Yeah, I think those those were really good studies. Also, I was at your talk and I really liked
Thank you for being there.
the talk. The other study it's about 5 or 6 years old now, and I thought it was also really good. And they took 2 buckets of people with anterior knee pain, people who were like good exercisers and people who were exercise naive. And they took the exercise naive people and gave them either a set of exercises for their anterior knee pain, basically knee exercises, quad and hamstring strengthening. And then they gave them hip and core strengthening. And they found that those exercise naive people did really well with the quad and hamstring strengthening, which are simpler exercises. Then they took the same set of exercises and gave them to people who had exercised a lot and found that the core exercises, so the hip strengthening, the ability to use your groin and your hip abduction or your ability to move the muscles out, really made a big difference. And it shows that the important part of physical therapy, or one of the important parts of physical therapy, is really tailoring that program to what your needs are. But the bottom line is both groups improved considerably, and they both were able to get back with that physical therapy to their previous level of function. So I thought it was great in that they proved their overall point, but they also found that when you did the right exercises, everybody got better. And even if you didn't do the right exercises necessarily, you're still going to get a fair amount better. So the PTs can tailor that. Now, I want to talk a little bit about symptoms. So when you have patients with anterior knee pain, what are some of the symptoms or words patients use that make you not too worried about it?
Yeah, and that type of pain, it's usually like pain at the front of the knee, pain going up and down stairs. We've got tons of hills here and stairs, and anything like that can trigger the pain. Um, I think one of the things that does worry me is when people talk about swelling. So if their knee it just swells up at the end of the day, or like I go for a hike and it's swollen every time, that gets more concerning for specifically like a cartilage problem. And then if it's like, yeah, my knee pops out or it's unstable, that definitely gets concerning too. Usually that people know that they've dislocated their kneecap, so not a subtle finding. And then a lot of the other symptoms, even like some cracking, some noises, some things like that, those can be normal or not problematic. And even like sometimes the knee will sort of give way, like it hurts so bad going up and down stairs that it just kind of buckles. And all of those can just still fall in that spectrum of normal. We'll be able to get it better without any kind of more drastic intervention.
Yeah, my two red flags are swelling and my kneecap is dislocated. Otherwise, I'm almost always going to start non-operative management first. So oftentimes patients come to us and they've had an MRI and they say, well, why do I need x-rays? And I think it's a whole nother discussion to talk about the importance of x-rays. But I think touching on the importance of x-rays in patellofemoral problems, really, because that gives us such a good alignment picture when your knee is loaded in different positions when we get x-rays, because we can get them standing up, we can get you bent to a certain angle. And there's definitely things we look at. And for me, at least, understanding the anatomy of your patellofemoral joint is largely based on x-rays. And I would imagine that's true for you too. But I wanted to transition to MRI. Oftentimes when we get this, there's a whole list of things that say this is wrong with your knee. What is patellofemoral?
Yeah, and so chondro is cartilage, and then malacia, like bad, so like just some bad cartilage, some abnormality at the cartilage, and that can be any. Usually, it's thinning or some change in that signal. So with the MRI, it's picking up differences in water content. And so, some change in that makeup of the cartilage, or there's some swelling in the cartilage, or some overload or signs of overload that, you see on the MRI. It's an incredibly common finding that, if you just took people without any knee pain, especially like runners, people who've been really active, like you will find, signs of cartilage wear, signs of even like complete cartilage loss in areas, especially at the kneecap, that, it's almost a surprise if that doesn't show up on the MRI report.
Yeah, for me, I think the chondromalacia, the patella, which is a horrible term for it, is kind of like,
so bad.
I know it does. It's so long too. It barely fits one line. I think that's the knee equivalent to AC joint arthritis in the shoulder. It's there. It's almost a ubiquitous finding. If I don't see it on the imaging report in somebody over the age of 35 to 40, I think the radiologist probably missed something. And it's just an age-related finding. Therefore, it probably doesn't mean anything other than you've lived a healthy life.
Yeah. Well, but also there are times that it can be, I think that can be the primary symptom driver.
If you're swelling.
Right. And I think that's like the biggest thing is like trying to figure out, is that it, or is this like that, 95% case where that's just a finding and not really a problem.
Now, what about injections? So I think a lot of times we hear about patients that, or our friends really, who have had injections into the knee, whether it's a steroid injection, a Synvisc or hyaluronic acid injection, or fancy PRP, stem cell, exosomes, lipogems, a variety of different
magic,
questionable injections. How do you use them in your practice?
Yeah, I think they can be really helpful. And I think one benefit that they can offer is sometimes like the knee is really painful and you can't even get started on like a rehab program. So it's just getting the thing to calm down, and then you can kind of start progressing through the strengthening and finally make progress and kind of just, turn the symptoms around. Another, I think, real benefit is that ability to confirm if the pain is inside the knee joint itself, or if it's external to the knee. There are a lot of things outside of the joint that can also cause pain. And usually those are things that we won't treat surgically. We're better at the things inside the joint. But if you have an injection, it takes away all the pain, even temporarily. That gives us good feedback that, that pain is almost certainly like internal to the joint, and then might be something that we can, resolve surgically down the road. And I think, there are a lot of concerns about like steroid injections in particular. And we know that like basically anything you inject in the joint is negative to cartilage. It's such a sensitive tissue. But I mean, I think one-time injection is probably very safe. Definitely get concerned if it's an otherwise healthy joint with just repeat injections over and over time, especially too frequent. But one time to take an inflamed joint back down to normal, I don't know. I think it's probably like, there's a risk benefit ratio, but probably a pretty favorable one.
Yeah, I think especially if the benefit is getting back to exercise, getting back to your previous level of activity, establishing a diagnosis with a single injection, it's sort of like taking an airplane to see your family. It's relatively risky. It is more risky than sitting in your house. You are exposed to radiation when you're flying, but it's such a small amount of radiation. I think the biggest risk is probably seeing the Cinnabon at the airport and deciding that you want a giant Cinnabon on your way to the flight, and then your hands are all sticky and you're
all benefit.
Yeah, you're one year closer to death.
Yeah.
So let's finish up and talk a little bit about surgery. For patellar instability, I think it's actually for us, especially in the younger patient population, when you've had a patellar dislocation, it's a relatively straightforward problem. The way I like to think about it is there a soft tissue restraint problem? Do you need to reconstruct the ligament that holds your kneecap from dislocating to the outside of the knee? Or is there also a bony problem that's predisposing you to do that? And I think those are pretty easy, especially with X-ray, for us to figure out where your kneecap sits, how high up your kneecap sits, what do we need to change so it doesn't happen again. And the nice thing is over the last 5 years, we've really gotten good 10 to 15-year outcomes with a lot of these procedures, and we know they're very durable for people with patellar instability. But I wanted to ask you about people with some cartilage loss and how we address those patients, because I think when we think about people with patellofemoral early arthritis or patellofemoral cartilage loss, it's a relatively common thing. I know we've talked about it being uncommon in the anterior knee pain world, but in general, this is a place where people can lose cartilage, and these patients are quite symptomatic. And I think it is where we can intervene and make their quality of life different. So first of all, when do you think about patients to have surgery? What is your you have some patellofemoral arthritis, this may be something that we can treat. What are your kind of things that you look for in a patient to say you are going to be indicated for surgery?
Yeah, and I think when they have like a cartilage defect, like where it's either completely lost the cartilage or like very high grade where essentially that cartilage is lost, generally that they like a desire to be active, and then their activities are being limited by pain and swelling especially, and then that they have good strength, that this isn't a strength, a coordination, these other factors that are leading to the symptoms, and then that they've tried other measures to try to treat it. And I think the biggest thing is like the rehab for those types of surgeries can be like pretty long. And so if you're signing up for like a year-long rehab where like a single injection would solve it, it's just like it's so much easier to say, well, like, will that injection solve my problem? Or will a couple weeks of physical therapy put me on the right course? Or do I really need to go through 9-12 months of like surgery and then rehab recovery, and a big to do. But yeah, I think especially figuring out, does it seem like that cartilage injury is responsible for the symptoms? And then, planning out a way to, restore, regenerate cartilage. We have a few different ways to do that, depending on, where the defect is, what it looks like, sometimes patient characteristics. And, a lot of them can be very successful, but some of it's on us to just make sure we're choosing the right option.
Yeah, I think when I think about surgery to restore people's patellofemoral joint, I really think about where is the cartilage injury located. If it's on the outside of the knee, it's easier for us to treat. And then does that cartilage injury involve a fair amount of bone or not? If it doesn't, I think it's in a lot of ways we can do what's called a autologous chondrocyte transplant, where we take your own cartilage out, mince it up, grow it in a lab, very fancy lab, and then put it back in on a special scaffold. In conjunction with that, we'll often move your kneecap over by cutting where it attaches at the bottom of the patellar tendon. But if you also have a fair amount of bone involvement, we can also take a donor cadaver, piece of cartilage and bone, and fix both the cartilage and bone problem. And I think the tough part for patients and for providers, for that matter, is there aren't great randomized controlled trials to say, in these 2,000 patients, we have figured out that this is the exact right cartilage procedure for this patient. This is the exact right cartilage procedure for that patient. But the end result, even in head-to-head studies, is for the most part, we're doing a good job picking the right surgery. Yeah. And the patients do really well after this, despite the fact, like you said, it's a 7 to 12 month recovery before you're really good. But these surgeries are lasting 10, 15 years. And if you take a 40-year-old and delay their need for a joint replacement until they're 55, 60, not only will the technology for knee replacement get better, but you're giving them an unfettered, good quality of life with a surgery that really, even though it's a big surgery, is no different than recovering from an ACL in a lot of ways.
Yeah, totally.
Well, thank you for giving us all your knowledge on patellofemoral problems, Drew. It was hopefully really informative. I've learned a lot from your instructional courses over the years, how you deal with patients. We share a fair amount of patients, and I think they always agree that your treatment algorithm for this complicated problem is really second to none. So thank you.
Thanks.